So now let's turn to the three FLT3 inhibitors, two that are approved, one that will hopefully or likely be approved next year. I'm going to start with what we've had since last year, April of 2017. Midostaurin, turn to Naval to give us an update there.
All right, sure, yeah. So it's been very exciting in the FLT3 field. So midostaurin is the only approved FLT3 for frontline induction therapy at this time. This was based on the RATIFY study, a multi-center, multinational phase 3 study, and as we've commented, took a long time because they had to screen 3,500 patients to find the 700, 20-25% incidence of FLT3. The study had midostaurin given on induction and consolidation, not with the chemo. It was given day 8 through 21 with the 3+7 backbone, and the same was repeated during consolidation, day 8 through 21. And then there was a maintenance built in where after you finish your 3 or 4 consolidations, you would get day 1 onwards continuous maintenance for a year with mido or placebo, depending on what the arm the patient was on. And the primary endpoint was survival. So the study read out, was presented by Dr. Stone at ASH a couple of years ago, showed the survival endpoint benefit had been met. The absolute survival benefit was about 7 to 8% with a 55 versus 46% survival. And when an intent to treat, they did see when you captured all responses over time, there was a significant improvement in the CR/CRI rate. In the initial cutoff, it wasn't met, but with the complete follow-up, there was a improvement. So I think the study, has shown benefit. Now, we weren't jumping for joy. I mean, it's not clinically solving the problem, but it was the first study, and it's hard to believe it was only 2-3 years ago. It was the first study to show targeted therapy is going to push the bar in AML, and conceptually, I think that step is a big one, and now we hope we will improve further with some of the more targeted agents. And I think the other thing that was very nice with the study update was the tolerability. So midostaurin, was in general well tolerated, has some side effects. A lot of patients have complained about this taste change or the way the pill tastes, and there is some increase in skin rash, but not major, that led to discontinuation. And one important thing for the community doctors especially, we have seen a few patients with pulmonary issues with this. So I think you have to, it's rare, 1% or low, but as this is used more, I think people need to keep an eye. If you see this may be an indication to start steroids, call your local academic center. But in general, very well tolerated, no major toxicity, and led to the approval of the agent. One point that Rajit mentioned I think will be very important maybe for the next group of FLT3 inhibitors that are going to be approved in salvage is that they did a subset. They did two important stuff. They did many, but two I thought were really important in the community. One was the benefit was incrementally seen across all allele burdens. And they did FLT3 ITD low, they did FLT3 high ITD high, and TKD. It did not switch your FLT3 ITD high, which is a bad group, to a favorable group. And that's too much to expect. But it gave you the same incremental benefit. So if you're poor, you did less poor. And if you were good, you did more good and better. So I think the point is you use the midostaurin, and the transplant decision is something we're all still trying to figure out. Do we transplant all of them? Not in our practice, we have been. And the second thing was they did an analysis at the time of relapse. And I was surprised to see they saw almost 40 to 50% patients had lost their FLT3. And then we had done an analysis in the past that 10 to 15% could gain FLT3 who didn't have it. So the point is, when you get to gilteritinib, quizartinib, you need to check at that point in time. You cannot say a year ago the guy was FLT3 positive, let's give him these drugs. So yeah.
That's one concern I have when we look at what's the outcome of FLT3 mutated AML at relapse. If they didn't look then, you don't know if that's what they're studying at all.
Exactly.
Many of these studies looked at initial diagnosis and then when they relapsed and assumed it was the same, and it may not be.